Hello, everyone. Good evening, and welcome to the EUROGEN webinar series. I'm Michelle Batty, the manager of the European reference network that we call EUROGEN. EUROGEN is one of 24 European reference networks, all created and kindly funded by the European Commission. They all deal with patients with rare diseases who need highly specialised healthcare. And in Urogen, we deal with rare urorectogenital diseases and complex conditions that need highly specialised healthcare. So we move from the paediatric to the adult to the rare cancers. So, what do? Well, we aim to deliver quicker specialist evaluation and more equitable access to high quality diagnosis, treatment, and care for patients with rare urorectogenital diseases and complex conditions. So that's what we're all about. And one of the main new services that we can provide as an ERN, we have an IT tool called CPMS, the Clinical Patient Management System. And this allows us to do cross-border, safe and secure virtual consultations on any tricky case that falls within the scope of our network. So I really encourage everyone. We've just upgraded the system with IBM. We'd be delighted to test it with you, and we can have virtual case discussions with the clinicians in our network that are probably treating high volumes of patients with these rare diseases. So please feel free to contact us. It's completely free of charge, and I'm assured Darren or Parmida can get you onto the CPMS in less than half an hour. And it's completely free of charge for any clinician in the EU, Norway, or Ukraine. So please don't be shy. We'd love to see those numbers racing up. So do get in touch with us via our website. We also write clinical guidelines. We do training and education activities together, and we also have a registry. And that's very exciting because actually, Eurogen is made up of 56 healthcare providers in 20 member states. And we all know the problem with rare diseases is fragmented, scattered data. And the idea is the Eurogen registry will be able to pull this data together across a number of hospitals and countries at European level. And really, we need to do this at scale to understand more about the research needs for our patients. So, about tonight's webinar, well, it's about the applicability of microRNA studies in testicular germ cell tumours. And our presenter here tonight is Dr. João Lobo, and he's a pathologist at the Department of Pathology of Portuguese Oncology Institute of Porto, and he's also a junior researcher in cancer biology epigenetics group, the research centre at IPO Porto, and he's assistant professor at the School of Medicine and Biomedical Sciences at the University of Porto. Please feel free to ask questions, and it's an honour to have you with us here this evening, Yao, and I'm delighted to give you the floor. Thank you so much.
Thank you. Thank you so much for the kind introduction. I will start by sharing my screen. Well, thanks again for the kind introduction, and I would like to start by thanking the organizers and Eurogen for putting together this webinar and for the opportunity to talk about this, which is one of my very favorite topics, the microRNA testing in testicular germ cell tumors. So thank you a lot for having me, and I hope you find this webinar interesting. Um, I leave here just a quick overview of the talk. I'll start with a brief introduction, and then I'll try to put you on track of where we can use microRNA testing in different settings of testicular germ cell tumors. And I hope that I can convince you that if we combine pathology, epigenetics, and developmental biology all together, and if we look at these three components of germ cell tumors, we will be on the right track to uncover new biomarkers. And I'll try to use the case of microRNAs to show you this. And I have no conflicts of interest. And so I would like to start with biomarkers. This is what we are addressing today. And of course, we all know there are different classes of biomarkers, the diagnostic ones, the ones that are used for monitoring disease, prognostic, predictive. But what we all know is that biomarkers should meet clinical needs. And the need is exactly to help our patients in different phases of his disease course. And I would like to make the case and the point that I really believe that pathologists as healthcare providers, are in a privileged position to uncover new biomarkers, both in tissue, because we do see the disease under the microscope every day, so we can really try to understand it, but also why not looking towards liquid biopsies? And we will be addressing this today, as the microRNAs are a very good circulating biomarker. And I really think this is important and also part of the domain of pathology. Of course, when we are trying to generate biomarkers for testicular cancer and for testicular germ cell tumors in particular, we have to face some challenges. And the first one is that these tumors are not so common in daily practice. That's exactly why they are part of this EUROGEN. Um, because they are not so common in our daily routine, and also to make things even more challenging, they are very heterogeneous. So there are very different histological subtypes of germ cell tumors, and there are indeed advantages of referral of these patients to specialized centers, to reference centers, where we can find multidisciplinary teams of professionals that will be more used to handling these patients and this type of specimen. So this is one of the first challenges. We have been trying to do exactly that here at IPO Porto. We are a reference center for treating these patients, and in close collaboration between the Department of Pathology and the Urology Clinic, we have been gathering and characterizing big number of samples from these patients, and this is a way to overcome the hurdles of working on this tumor model. They are rare, but if we work together and put the effort, we'll be able to get to more clinically meaningful results. And of course, again, stressing the role of pathology, a centralized review of pathology is very important. It's important for clinical management, but also for giving important input on clinical trials, on research protocols that are really so important and can make a difference. And also having experienced geopathologist that is used to look at these tumors on daily routine has a lot of benefits for discussing challenging cases at MDT meetings. And also these pathologists may be more in touch with some advanced methodologies like the microRNAs that we are addressing today. Another thing worth mentioning is that testicular germ cell tumors are really fascinating, at least to me. And one of the reasons is that they are really very much linked to embryonic and germ cell development. So there's a very strong link with development and developmental biology. And actually, if we do this exercise of looking back, we see that developmental biology was always the trigger to make very strong and useful discovery of a biomarker that made its way to the clinic. This started actually many years ago when AFP and HCG were discovered as very important tumor markers for these patients, and they still are. Then the discovery and better understanding of a pluripotency factors and this network of factors that we actually use on immunohistochemistry every day to classify the tumors. And this kind of input from developmental biology also led to the discovery and realizing we could be discovering a new biomarker, which are these embryonic microRNAs of the 371, 373 cluster that I will be addressing today. And another aspect of germ cell tumors, we are used to thinking of tumors, thinking of tumor mutational burden, but actually, testicular germ cell tumors are located on the lower end of tumor mutational burden, like other pediatric kind of cancers. But on the other hand, the impact of epigenetics is really very important in germ cell tumors pathobiology. And so if we focus on epigenetic biomarkers, we may get to more interesting biomarkers and results. And this is where we can find in epigenetics also the non-coding RNAs. And this is where also we can find the microRNAs that we are addressing today. So this has been more or less our idea, trying to combine these three aspects to find new biomarkers that can tackle important clinical questions that need answer. And now I wanted to turn to microRNAs, which is really the topic of the talk. And to start with liquid biopsies, it's not news to anyone. We know that liquid biopsies are here to stay, and they are really important and the source of a lot of different information and biomarkers that can really help us treat our patients and monitor them. But the story for testicular germ cell tumor patients with microRNAs, actually, it's not new. It started already with the seminal paper on Cell in 2006, where these authors identified a cluster of embryonic microRNAs, of microRNAs of a specific cluster that were really overrepresented in these tumors and not on other tissues, other kind of tumors. And why are we so happy and excited with these microRNAs as biomarkers? As the name implies, the microRNAs are very short, so they are 22 to 24 nucleotides in size. They're really, really short, and this makes them very stable in circulation in any biofluid. They also have a short half-life, and they can be detected in these biofluids by simple methodologies, like a simple qPCR, which has a low cost and is also universally available. And so they check a lot of the boxes that we want in a circulating, in a non-invasive biomarker, which is really needed in this tumor model and has a lot of strength. And actually, if we look at other urological tumor models, we see that testis cancer and germ cell tumors of the testis are the clear front runners when it comes to microRNAs with actual being promising in the clinic and for application in the clinic. But are we forgetting or putting aside the classical markers? For sure not. The classical markers, AFP, HCG, and LDH, they are useful. They will continue to be useful. They're even important for staging our patients. However, we also know they have some limitations from time to time. They, for example, are elevated in up to 50% of patients at diagnosis. They are dependent on the histological composition of the tumor, and this is something that is worth recalling. And this is where the microRNAs of this cluster have been outperforming the classical markers. And so what I think can be useful is to combine the microRNAs with the classical serum markers, not to replace them, but to combine both biomarkers to better help our patients. And these microRNAs of this cluster are really positive and detectable in all germ cell tumor types except teratoma, and I will come back to this aspect more towards the end of my presentation. And this is a good time to address microRNAs. We know the Nobel Prize in Physiology and Medicine 2024 was attributed to these two researchers that uncovered the importance of microRNAs. So since that seminal paper in 2006, you can see here the PubMed search showing the huge number and increase in publications focused on microRNA testing in testicular germ cell tumors. And I decided to bring this great systematic review where the authors reviewed the literature until this date, and they show good sensitivity and specificity of this biomarker for detecting germ cell tumors and also in different settings of the disease, not only pre-orchiectomy, but also for monitoring response to chemotherapy, for predicting histology at the retroperitoneum in the case of a metastatic patient, even after chemotherapy. So they can be interesting biomarkers in different settings of the patient history. And these are two major studies that I always like to show, published at JCO, where you can clearly see, and I want you to memorize this graph. It will be important further in the presentation, where the microRNA 371 alone has a higher sensitivity compared to the combination of the three classical markers that we have available in routine. And here the ROC curve for the microRNA 371 is really a very good one. So there are several research articles showing the real-world application of this microRNA 371 test. MicroRNA 371 has been the assay that has more that has been used more in the literature compared to microRNA 372 and 373, which are other assays part of the same cluster. I also wanted to highlight this paper where patients showed high acceptability of having this additional test part of their follow-up, and also this cost analysis where the authors show that introducing the microRNA 371 may actually lead to savings in healthcare costs by giving the clinicians more convincing the clinicians during follow-up to reduce the amount of CT scans that are performed, for example, during follow-up. And now I wanted to discuss these microRNAs in different settings of the disease, starting with stage 1 disease. And here we really have to focus on stage 1. We know the majority of tumors present in stage 1, and we really want a biomarker that can detect relapses and actually that can discriminate patients that are at risk of relapse. And these are the ones that benefit from adjuvant chemotherapy, platinum-based, from those that can be safely maintained in an active surveillance protocol. And this is really important. We know the big issue at the moment in testicular germ cell tumors is overtreatment, and these young individuals will have to endure the long-term toxicity of exposure to chemotherapy, either cisplatin or even bleomycin and other compounds. So this is really an important question. And I decided to bring some articles focused on microRNA testing in stage 1 surveillance cohorts. This is one of those papers. You can see here the microRNA 371 reflects the natural history of the disease in a sense that it goes down after the orchiectomy and it goes up at the time of relapse. And here at the time of relapse, 94% of stage 1 patients in this cohort had elevated or a positive microRNA 371 test, compared to only 38% of patients having elevation of any of the classical serum markers. So here a big difference in the ability to detect a relapse. This has been also shown by additional studies. This study added that the microRNA 371 could detect recurrences at a median 2 months earlier compared to the standard follow-up investigations, including the CT. And this is a German study. Also, here you can see the higher sensitivity of microRNA 371 assay for detecting relapses compared to the sensitivity of AFP and HCG. More recently, we have been trying to focus on even smaller tumors with smaller disease burden. So it's expected that these tumors secrete lower amount of biomarkers. These very small testis mass is inferior to 2 centimeters. The classical markers are usually negative in these tumors. And this Italian study, they showed that the microRNA 371 test could detect with this sensitivity and this specificity when these small masses were actually germ cell tumors or another kind of lesion, which was not sometimes even neoplastic in nature, or that it wasn't a germ cell tumor. Of course, you can see here this RQ value, and different cutoffs will lead, of course, to different performances. And this is an important point when we're discussing this test. This is still a bit debatable, but the uh, threshold that we defined for test positivity perhaps could depend on the setting of the disease that we are studying, but this is something that is still under discussion. Also, these studies showing the same kind of data on small testis masses, but here the same samples were run in 3 different labs in 3 different sites with different methodologies, and this was just to illustrate that the performance was, as you can see here in the rock curves, different between the different sites, and this is showing that methodologies really do matter. And these variables are really important if we want to define a universal protocol for performing these tests. So we really need more of these interlab comparisons for this test. Now, switching gears and going to metastatic disease and actually to teratoma. Of course, it would be really great when we have RPLND and disease in the retroperitoneum to be able to discriminate necrosis from only teratoma from non-teratoma disease. This would be the ideal biomarker. Actually, here I wanted to start with the role of microRNA 371 in chemo-naive RPLND. So here the studies show that the microRNA 371 test, as you can see here in the graph, is really behaves quite well. The microRNA 371 is positive when there is viable non-teratoma disease. So this is really quite helpful. And here in the post-chemo RPLND setting, we can see the same kind of graph. The performance may, of course, vary, and I brought this meta-analysis where you can see the pooled sensitivity and specificity of the studies available. But actually, beyond the numbers, what I want to highlight are some of the limitations. There's still in these studies lack of standardization. So related to what I was telling you about in the previous slides, the different sites use different methodologies and pipelines with small variations, but that can make a big difference regarding testing of microRNAs. And also, of course, we have this problem, as I alluded to in the beginning, the microRNA 371 is negative specifically in teratoma, so we do not have a biomarker that can distinguish teratoma from fibrosis after chemotherapy in the retroperitoneum. And of course, this is a limitation. And regarding this, there was some hope some years ago, some studies um, found in tissue studies that microRNA 375, which is another microRNA of a different family, seemed to be upregulated in teratoma, but the liquid biopsy studies that followed with some variations between them, but none showed the same kind of performance that we were expecting. And actually, and this is reviewed in this review article, we are facing this teratoma challenge, and everyone is trying to find a biomarker that can be specific of teratoma so that we can then combine it with the microRNA 371 and generate a combined panel of biomarkers that can be really even more a game changer. New avenues for biomarkers in liquid biopsies and for detecting teratoma. I found this article quite interesting to combine it with microRNA 371 with radiomics. This could be a way to go. Combine it with ctDNA, some data presented at ASCO, but still very few data out there. But we should see what the next years will bring about ctDNA in germ cell tumors of the testis. And I brought this work by my PhD student, Nuno. And Nuno here studied extracellular vesicles, and there seems to be another family of microRNAs that can be involved in the generation of teratomas. So this could be further studied to see if we can come up with a biomarker of teratoma also that can be detected in circulation. But of course, we have to always remember, and I'm alluding to this again, the pre-analytics and all different variables that compose this test. We really need to make up a universal pipeline, discuss what kind of blood collection tubes should be used, which extraction, RNA extraction kit should be used, should we use pre-amplification or not, how do we normalize our assay, how do we quantify it, and how do we report it? Should we test serum? Should we test plasma? And these are two different components that can be derived from blood. And here I think the input of pathologists can be critical because we're really used to discussing these pre-analytical variables. Now in this other section, I wanted to show how we can use this microRNA test to better understand some phenotypes of germ cell tumors, which are even rarer. And so we don't know so much about their pathobiology. And starting with this type of tumor, the cystic trophoblastic tumor, which is more common after chemotherapy in the retroperitoneum. And here in this study, for example, we showed that the cystic trophoblastic tumors were negative for microRNA 371, like the teratomas, and quite different from the choriocarcinomas that you see over here, which were positive for microRNA 371 as expected. And this kind of supports the theory of a maturation phenomenon towards teratomas. So this makes a lot of sense since the cystic trophoblastic tumor in the retroperitoneum actually behaves a lot more like a teratoma and not really like an aggressive tumor form like the choriocarcinoma. This is another study that I decided to discuss, and these are collaborations with Indiana University and the group of Andy Acosta. Here we focused on spermatocytic tumors with aggressive behavior. These are really quite rare, but when we look at a cohort of these, the aggressive spermatocytic tumors had an upregulation of microRNA 371. And we believe that in these aggressive spermatocytic tumors, microRNA 371 could be a feature of aggressiveness and a biomarker that translates this aggressiveness. And here I also wanted to highlight somatic malignant transformation arising in germ cell tumors. This is really important to detect in our testis cancer specimens. We know that this can happen in metastatic sites more frequently, but also in the primary tumor. But here in the metastatic site, you can see here how the prognosis is really poor. These tumors are unresponsive to most of the treatments, and resection is really important. And when we looked at very different phenotypes of this somatic malignant transformation, we could conclude with microRNA profiling that at least a subset of these somatic malignancies seem to derive actually from yolk sac tumor and not necessarily from teratoma as it is in the current WHO classification of testis tumors, and these, among other uh, topics and data out there, led to this proposal of reappraisal of the current classification. And finally, this other study looking at low-grade glial tumors arising in germ cell tumors. This is also a rare event, but again, combining DNA methylation and microRNA testing on these tumors and contrasting them with embryonal neuroectodermal tumors, ENTs, we found evidence supporting a maturation phenomenon of these low-grade glial tumors towards teratomas. So this leads to a better understanding of these tumor types, which are really quite rare. And finally, I wanted to end the presentation by showing you some examples of microRNA testing with an IVD test at our IPO Porto. So having said all this, the fact is that there is a commercial test available out there for the microRNA 371, which has IVD approval, and we have been using this test and giving this test to our patients in it's a blood test in serum to all testicular masses at diagnosis and also to all testicular germ cell tumors during their follow-up. We started in August 2024, and this is just our circuit here with the clinician asking for the test. The patient goes for blood collection. And then the blood is brought to our Department of Pathology. We perform the whole test at the Department of Pathology. This is the test, the cDNA synthesis, and the real-time quantitative PCR protocol that we perform here in our molecular pathology lab. We extract the results from the software, and then we produce a pathology report, a molecular pathology report, which is then communicated to clinicians and can be another source of information that can be integrated with everything else, like the classical markers and the clinical history and imaging, to make a more informed decision. And this has been our way of working since we introduced the test. These are very preliminary analyses. We have tested more than 150 samples by now, different settings of the disease, and so different phases of the disease we got a sample from. But again, like the other graphs I showed in the beginning, the microRNA 371 alone has a superior sensitivity compared to the combination of the three classical markers, which you can see over here. And to make this more interesting, I decided to bring concrete cases. These are some cases we have seen. This is one from last year. It's a 28-year-old with a 1.9 centimeter mass on the testes. The classical markers were negative, but the microRNA 371 was positive. This was the surgical specimen. And indeed, here you can see this nodularity, which on histology corresponded to a seminoma. This is another patient, 35-year-old, 5 centimeter mass on the testes. This is a case from 2 weeks ago. Markers were completely negative, but the microRNA 371 test was really very much positive. And you can see the testis is completely occupied by a large seminoma. Again, microRNA 371 was positive, but the classical markers are negative. This is a 34-year-old male with a 2 centimeter mass. The markers are negative, and the microRNA 371 again was positive. This was the surgical specimen. You have here a heterogeneous tumor at the lower pole of the testis, and you can see this ended up being a mixed germ cell tumor, 90% embryonal with 10% seminoma, syncytial blast cells, and this was actually a PT2 tumor, so it had lymphovascular invasion. And it did not elicit elevation of the classical markers, only the microRNA 371 was positive. To have some contrast here, we have a 50-year-old male with a 3.5 centimeter mass. The markers were negative, but the microRNA 371 was negative as well. This was a large tumor, and this ended up being a sex-scored stromal tumor. So this is another family of testis tumors. It's not a germ cell tumor, and it makes all sense that these tumors do not give a rise in microRNA 371 because they have a different biology. This is now a 32-year-old male. This is a 1.8 testis mass, so a small testis mass, marker negative, microRNA 371 negative, and this ended up being a simple hemangioma, which is a totally benign lesion. When we collect serial samples along the way, we can also make these patient profiles, which I personally think it's the most informative. We should not look at a single measurement isolated. I think any biomarker is more valuable if we have its profile. And for example, this is a patient that was diagnosed with a seminoma in the retroperitoneum. And then looking at the testes, it had a burnout tumor, so a regressed germ cell tumor in the testes with a metastatic seminoma mass in the retroperitoneum with positive microRNA at this stage. It was treated with chemo, and after chemotherapy, with one or two courses, the post-chemo sample was completely negative for the microRNA 371, and then we got the histology of the RPLND, and it had only teratoma, so explaining why the microRNA 371 turned to negative and showing that the seminoma component completely disappeared. And now showing some examples of RPLNDs. This is a 28-year-old male, 7 centimeter retroperitoneal mass. The patient had a mixed germ cell tumor in the testes, had chemo, had this mass in the retroperitoneum. Markers were negative, but the microRNA 371 was positive before the surgery. The patient went for RPLND. This was the resection specimen with some lymph nodes here on the side. And here in these two areas, in two slides only, we could find 20% of embryonal carcinoma and yolk sac tumor with the microRNA 371 being positive. And this explains why it was positive, because there was actually non-teratoma disease, which could not be captured by the classical markers alone. So these were my last slides. I wanted to finalize by making the case that to proceed in germ cell tumor research, I really think we must have access to well-defined and relevant germ cell tumor tissue and liquid biopsy sets with very good clinical annotation. And then we should bring our questions into the lab, use in vitro models, in vivo models of the disease, and try to get the answers and bring them from the lab bench to the clinic. This is what we have been trying to do in our translational research. And I really think this is the only way to move further, is to work together in multidisciplinary teams. And it has been really very nice and very interesting to collaborate with a multidisciplinary team. And this is also what I wanted to highlight. It was highlighted in these recommendations of the MAGIC Consortium. And the input of pathology is really important if we want to revise all our histological material and get the best out of our biomarkers. So only working together, everyone together, we can find the missing piece of this puzzle, which are the germ cell tumors. I wanted to finalize thanking our collaborators. I wanted to thank everyone at IPO Porto, the urology clinic, the nurses, all the healthcare providers, the patients, the research center, and everyone that has been helping us put this together, which is challenging every day, but we make it work. And I wanted to end by showing you a picture of our lab group. This is the cancer biology and epigenetics group, and this is the IPO Porto and the Department of Pathology, which is over here. I'm sitting somewhere more or less in this room at the moment. And thank you again for inviting me, and I'm happy to take any questions.
Okay, thank you very much. It's a very interesting presentation. So I will I can stop sharing your screen 1 second and let me. Oh, that's you. Yeah, great. Thank you.
Yeah.
Okay,
Yeah.
so yeah, I'll invite everybody now to put in your questions. We've already got one question actually, João. So I don't know if you can click on your Q&A button. You should be able to see the question we've already got.
Absolutely.
Yeah. So if you just read it out, and then I think there were two questions there actually, but you might want to do them separately. So, but go ahead.
Okay. So we have here a question: can microRNA also be used in the diagnosis of testicular tumors in children? So good question. Yeah. So I will highlight the types of germ cell tumors where we have less data are perhaps precisely the pediatric tumors, the ovarian germ cell tumors, and the extragonadal germ cell tumors, and this is easily explainable. We know that testicular germ cell tumors are by far the most frequent, but actually the studies we have are there, and also personally we have some projects ongoing in these kind of samples. We have also tested, for example, mediastinal germ cell tumors here at our center with the IVD kit. And we have evidence showing that the microRNA 371 also behaves quite well in this setting. We have actually very recently had a testicular germ cell tumor in a pediatric patient with a focus of, I believe, yolk sac tumor and some other component, and it was microRNA 371 positive. So the evidence out there, there are also some one or two publications, I think I recall, in ovarian germ cell tumors, one quite recent using liquid biopsies. So indeed, the microRNA 373 cluster can be used for the diagnosis of testis tumors also in children and other settings. Of course, we need more data, and this is because these diseases become even rarer in these settings. So multi-institutional studies would be very much useful so that we can actually show this in a large cohort. And here, what are the costs of microRNA testing? Is it less or more compared to the standard tests? Yeah, we do get this question a lot. The microRNA 371 IVD kit, it's more expensive than the classical markers for sure. It is around 300 euros, more or less, per sample. This is more or less the costs. Of course, I would also highlight the methodology. We're not speaking about very complex tests like dependent on NGS or something that has gives rise to a lot of workload. We're talking about qPCR assay. If a sample arrives in the morning and this is an urgent case and we really need to give the response immediately, we can start the extraction, cDNA synthesis, preamp, and give the results on the same day later on. And indeed, it's a useful test. And of course, related to costs, this also has to be contrasted with also application of CT scans, like I showed in the cost analysis. So yeah, hopefully I've answered the question. Oh, and I'm seeing more questions popping in. So I will read this one out loud as well. Could microRNA be used as a screening test in categories with a higher risk of testis cancer, say like maldecent or cryptorchidism syndromes? Very great question. Thank you for this. The honest answer is I don't know because we do not have the data yet. I have to say this is something I'm quite interested in finding out the answer to your question. We do need, of course, to stretch the sensitivity of the test to be able to detect such uh, tiny levels of these hypothetical levels of microRNA in circulation already when we cannot actually see there is disease. There are articles showing that microRNA 371 is sometimes able to detect GCNIS, but the performance, of course, drops a bit. This will all depend on how the field will evolve. We have tried, for example, I haven't showed, but we haven't tried some years ago to move to digital droplet PCR, looking for higher sensitivities. But in the end, we could avoid the preamplification step, but we did not get to a much higher sensitivity compared to the standard pipeline. But this is a very good point, and I think we really lack the data for this for now. What is the specificity of microRNA for defining viable versus necrotic residual post-chemo masses? So regarding specificity, and if we are talking when we mean viable non-teratoma disease, the sensitivity and specificity are quite nice. The necrotic material or teratoma, they should not elicit, and the available literature shows that most of the cases do not elicit any elevation of microRNA 371. This has been our experience also with the IVD tests. Whenever we get a pre-RPLND sample after chemo, we always correlate, even in the pathology report when I sign out the RPLNDs, I tend to correlate what I find in histology, and I don't recall any RPLND in our hands that was fully necrotic after total embedding, and this is something I wanted to stress as well. RPLNDs can be quite large. Sometimes they can be large masses, and we have to think of sampling as well. If we sample 2 or 3 or 4 sections of an RPLND, are we 100% sure there was no tiny focus of viable tumor there? So this is something also to have in mind. But the cases we have had so far, when the tumor underwent complete necrosis, they were always microRNA 371 negative. Of course, the main issue here is a teratoma would be as well. So here we really lack, and this is a drawback for sure, we really lack an additional biomarker that can discriminate teratoma from necrosis. This would be a game changer, because then we could make 2 qPCR runs, one for microRNA 371 to detect the non-teratoma disease, and one from this other biomarker that is yet to be discovered to identify teratoma. And then if both were negative, we would have only necrosis. We have another question here. If microRNA is positive with I think it should be GCNIS, is there a risk of false relapse being confused with early detection? Of a microRNAs. Survey lowered sorry. Does in practice would a positive microRNA on surveillance lower the threshold for a scrotal ultrasound? And if negative, could elevation still be due to I believe here should be germ cell neoplasia in situ. So if I understand correctly, so if we do have a microRNA 371 positive test, it indeed can signal a relapse, as we've discussed in the presentation. The data shows us this, but of course, if there's microRNAs primary being developed, so if there's another primary emerging in the other testes, it could be the reason for eliciting this rise in microRNA 371. Of course, as I mentioned, for GCNIS, the performance of the test is much inferior, so the sensitivity of the assay is not so good. Even for the small testes mass paper that we showed that are shown in the presentation, you could see that the sensitivity drops a bit compared to a full-blown cancer that is like 5 or 6 centimeters. So this microRNA is like any other biomarker dependent on disease burdens, and tumor size is a measurement of disease burden. But indeed, in a scenario where there's a tumor growing on the opposite side, the testis that is left, it could be the reason for elevating microRNA 371. And if there's a relapse, for example, in the retroperitoneum at the same time, both would contribute to this rise in the microRNA test. So I think it's this. Of course, we do with the current cutoff for the IVD tests, we are more expecting, and this is more planned to detect the tumors with visible tumors, so that are felt and detected on ultrasound and physical examination. I'm not sure if I answered the question, but please let me know.
Okay, yes, thanks, Alfred. Thank you for those really comprehensive answers. We don't have any more questions at the moment, so I'll just give people one more chance, a minute, to put any more in if they have them. Just in the meantime, I'll remind everybody that you'll get a survey at the end of when the webinar closes. You'll also be sent it by email as well, so you can fill it in immediately, or you can wait until you've got more time. But yeah, it's really good for us to get our feedback about the webinars. So if you can fill that in, that would be great. We'll also send a link to the recording. So this will put onto our YouTube channel tomorrow. We'll send a link to all registrants for that. So if you missed any, now you didn't catch the whole presentation, you better to watch it back tomorrow on the YouTube channel. So look out for that. So yes, we haven't got any more questions coming in. So we're just about almost pretty much on time, really. So that's good though. So yeah, if anybody thinks of anything else they wish to ask afterwards, or anybody's watching this back on YouTube and has a question, you can either email me or you can put it into the comments on the YouTube video as well, and we'll pick those up and pass them on to Xiao to answer. If that's okay, Xiao, I hope so.
Absolutely. Yeah,
Yeah.
I absolutely feel free to write me. I think I have my email address at the beginning of the presentation. I'm happy
Yeah.
to take any questions afterwards. And yeah, thank you. The questions are really interesting. And thanks for having me. It was really great to be here.
Yeah, well, thank you for taking the time to do this. Very much appreciated. And thank you to everybody for attending. Please, the other thing I'm going to say is just please check out, to the attendees, check out our website for the other upcoming webinars. We've got a lot we'll be putting on quite soon. There are some registrations that are open already and others that will be coming on quite soon. We'll just find the time to update all of that in the next few days. But thank you, everybody. Yes, I hope you all have a good evening, and hopefully see you all again soon. So please take care. Thank you very much.
Thank you. Have a good evening. Thanks.